Hello, guys. Welcome to today's session on gastroenterology. We've done embryology. We did embryology, finished embryology yesterday, and so we'll be going to anatomy with the hopes of finishing it today, and then we'll move on from there to physiology and pathology. Okay. So, um, we're gonna have the slideshow for reproduction today. So, um, let's all just pay attention closely. There are a lot of high yield stuff we're going to talk about, right? So let me share my screen with you guys. Okay, so give me a minute. So we'll be studying an anatomy of the GI tract. A lot of high yield things for you guys to know here. And so, yeah, so the anatomy of the GI tract basically, it starts with this very important high yield concept that you need to know. Um, Organs in the gastrointestinal tract that are located peritoneally. And so this picture gives a very good idea of the organs you should know, right? The mnemonics there is SAD Parker. It's in your first aid. I'm not really going to talk so much about it. But what you need to know basically is that in some STEM questions of the step one, it can tell you about a patient who was involved in a road traffic accident. And about 2 to 3 hours later, after all routine investigation, trauma series was done for the patient, ultrasound scan and all of that. Didn't really pick anything. And then they just discovered that the patient actually just slumped, just slumped and just lost consciousness. And they said 2 hours later, they did a CT scan and they would ask which part of the individual's peritoneum or where do you think the bleeding is going to occur. And so retroperitoneal hemorrhages are very, very fatal bleeds because on the initial screening of the patient, you might not be able to see that. And as you can see here, we have very, very significant blood vessels that run retroperitoneally, the aorta and the IVC. And so you can see how they are structurally. You can see that the aorta is kind of like adjacent to the IVC. And so if a patient has an injury, or a road traffic accident that leads to transection of the aorta, the patient will rapidly bleed out. And so it's very, very important for you to know these mnemonics. I'm not going to really talk so much about it. It's in your first aid, and of course, you can read about it. The next thing I'm going to talk about are the ligaments, right? I'm going to talk about the ligaments. And how I want you guys to remember the ligaments is that we have the derivatives of, first of all, basically, you need to understand that the way the GIT is formed, um, people generally think that the GIT is just one big here you have the organs here. So you have the stomach, the spleen, the intestine, the bladder. People think that this is how the GI is wrapped by peritoneum. This is how it's wrapped. People think it's just a circle where you have the organs inside. You have the what do you call it? The visceral peritoneum, and then you have the parietal peritoneum. But on the contrary, That's not how it is. The peritoneum forms like a blanket, a double layered blanket around all the organs. So basically, you have something like this. This is how it goes, right? This is how it goes. You know, this is how it goes basically. So, yeah, this is how it goes basically. So the organs are wrapped here. You know, they are wrapped here. So it's the two layers that are like wrapping it, forming a covering over it. So you can have this intestine here, you can have the stomach, you can have the liver and all of that. So you can see that it's more like a double layer that is wrapped. So there's usually a very um, large amount of space. And that's why when the organs in the stomach, you hardly have a situation where somebody has a peritoneal bleed and then it presents early because the peritoneum has a lot of space between the two layers. And so it will take a lot of time before you compress the parietal layer. The parietal layer is the layer of the peritoneum that is innervated. It's innervated by somatic fibers. So these somatic fibers carry pain, pain and stretch. And so it's only when blood has gathered to a significant level that you start having pain because the peritoneum has a lot of space between the visceral and the parietal. And that's why before you stimulate the parietal, it takes a long time because of that space. As against this diagram, this diagram, if somebody has a bleed, it can easily just spread to the peritoneum and irritate it. Okay. Now, the most important ligament here that I'm going to talk about, and it's very high yield for you guys to know for the exam, is the hepatoduodenal ligament. And why is this ligament important? There's something known as the Pringles maneuver. Pringles. So I'm just going to explain what that means, right? Pringles maneuver. So the Pringles maneuver basically is a situation where a patient, a surgeon, is attending to a patient in the OR, the operating room, and the patient has maybe a laceration to the liver, right? And the surgeon wants to kind of like ligate the blood vessel that's causing this. So you need to know that this ligament here is known as the hepatoduodenal ligament, right? And it carries some very important vessels, carries the portal vein, you know, the hepatic artery and the likes. And so this ligament houses about 80% of the blood that goes to the liver. So the portal vein and the artery, most especially the portal vein, carries about 80% of the blood that goes to the liver. And so in the operating theater, you're trying to find out which blood vessel is having the laceration. So what the surgeon does is that he clamps the hepatoduodenal ligament. He clamps it. So he puts a clamp across it here, right? This clamp is to kind of like see if the bleeding, the torrential bleeding from the liver reduces. It shows that the bleeder is from the portal vein or hepatic artery. If the bleeding does not stop, it shows that it's most likely from the inferior, the hepatic vein. So the Pringles maneuver is very important and is clinically tested in the exam, especially step 1. And it's very important for you guys to know this. This is very, very high yield, and that's why I'm kind of like spending my time to talk about this, right? The other ligaments that you need to know, the falciform ligament that connects the liver to the abdominal wall. Then there's also some other ligaments, the hepatogastric ligaments that kind of like connects the liver to the lesser omentum. These are not as high yield as the hepatoduodenal ligament. That is the one that's commonly tested in the exam, and that is the one I recommend you guys to focus a lot on, right? Okay, so
Please, can you go over it once more? Pringler maneuver.
okay, so the Pringles maneuver is a situation where a patient has maybe a liver laceration. So there's a laceration here. This is the laceration of the liver, right? And so the liver is losing a lot of blood, like so much blood, right? The patient is losing a lot of blood from the liver, right? And so the surgeon goes in, does an X lab for the patient. he wants to find out where the bleeder is from. And the problem is that the liver has two blood vessels that kind of like go and come away from it, right? And so the surgeon would have to go to this hepatoduodenal ligament and clamp it. He will clamp the ligament because the ligament contains the portal triad, which is the portal vein, the hepatic artery, and then some part of the bile duct. So this is what is contained in the hepatoduodenal ligament. And so the surgeon clamps it and then checks that laceration site. If the bleeding stops, it means that the artery, if the bleeding stops, it means that the blood, the bleeder is from the portal vein. So he clamps the vein, the hepatoduodenal ligament, and if the bleeding from here stops, it means that the bleeding is from here. But if he clamps it and he notices that the patient is still bleeding, it means that the blood is coming from the hepatic vein, not the portal vein. So what the maneuver just basically helps you to do is to kind of localize the artery you are going to ligate so that you can reduce blood loss in the OR, right? Surgeons use it a lot. And so that's why it's important for you to know in the exam. It's a very commonly tested concept that you need to know. So if you clamp the hepatoduodenal ligament, the bleeding stops. You're thinking more of the portal vein. The portal vein is where the bleeder is from. And if you clamp the hepatoduodenal ligament, the bleeding doesn't stop. It means that the bleeder is more from the hepatic vein, not the portal vein or hepatic artery. Because this here carries two major vessels, the hepatic artery and the portal vein. And so if you clamp it and the bleeding stops, it means that it's from one of those vessels in the hepatoduodenal ligament. If you clamp it and the bleeding is still up, it means that it's not from the portal triad. So it's more from the hepatic vein, right? That's what I want you to know about that concept. So I'm not going to talk much about the other ligaments because they are not as high yield as the others. You can know them for the exam, but I won't really discuss so much about them, right? So this is also a very high yield concept because this ties in a lot to pathology, this particular anatomy, knowing the histology of the GI tract. And so the first thing I want you to know is that the first layer that you encounter in the GI tract is the mucosa. And so the mucosa has three parts. Yeah, Dr. Jamil, go ahead. Did someone raise their hand? Okay.
Sorry,
so the amount of
I am the one. Sorry for inconvenience. Actually, my question regarding the Pringle's maneuver. If we clamp the hepatoduodenal ligament, definitely now we stop all the blood supply to the liver. Yeah. And the hepatic vein is the continuation of this blood supply, I mean the portal and hepatic. Is there any retrograde flow from hepatic vein that can cause the bleeding in the liver laceration?
Yeah, it can basically, because what happens there is that when you clamp the hepatoduodenal ligament, you would expect that blood flow should stop, just like you rightly said. But if the patient is still bleeding, it means that the blood is coming from the hepatic vein. Because you know what happens here is that all the veins have, the heart exerts a negative pressure. That's what happens when you inspire. When you inspire, there's a negative pressure that is generated. And so blood leaves the peripheral circulation and goes to the heart, right? But what happens here basically is that when you clamp it, you cut off that negative circulation. So what you are doing is that, just imagine you create a negative pressure and then you clamp it at the end. Instead of the blood going towards the heart that's generated the negative pressure, it will kind of like flow back, right? That's what's basically happened. And so the patient will bleed. The Pringle's maneuver is just, as the patient is bleeding in the OR, you just want to find out where the bleeder is, because you can transect a part of the liver and then some branches of the portal vein that branches into the liver can be affected. Similarly, some branches of the hepatic vein that arise from the liver going outward can also be affected. So the point is that you just want to identify while you're in the OR correctly which blood vessel is causing this patient to bleed torrentially. Because I told you that there's a negative pressure that the heart exerts that pulls all the blood from the peripheral circulation to the heart, right? So that's what just happens basically. Somebody asked about the omental foramen of Winslow. Yeah, so let me just talk about that, right? So basically, the foramen of Winslow is kind of like, how do I explain this, right? Let me use a diagram to explain this. The foramen of Winslow, let me talk about this. And so let's assume that this is the liver, right? And so this is the peritoneum, kind of comes like this, goes down, comes like this, covers, this is more like the bladder and the uterus. So I'm trying to just show something. This is rectouterine pouch of Douglas, right? And then it comes this way, right? And then it comes this way, right? So we have the intestines here, and so it wraps around it. And then it comes back up. You have the stomach here, right? And then what you have here is that it wraps around the stomach and then continues this way. And then it now goes downward, right? And comes this way. Comes this way. I'm sorry, my diagrams are bad. I'm not a good artist, right? I'm not a very good artist. I just want to illustrate something. So this peritoneum comes here, right? Wraps around the stomach, surrounds the intestine. So this one comes like this. So what we have here is that this one comes this way, forms a kind of like sac, and then continues here. This other one let me draw it properly so that you can have an idea here. And so what happens here is that this guy comes, right, folds on itself, forms a sac, comes this way, right, and comes this way, and then wraps around the intestine and goes this way. And so this whole place you're seeing here, is the greater sac. Right? This little part here within the stomach that has this space here is known as the lesser sac. And so there is a connection at this point between this greater sac and this lesser sac, an opening here where, kind of fluid kind of goes. It's peritoneum basically. So fluid enters, comes inside here, fluid leaves here, goes inside here. This connection between this great sac, like this sac you're seeing, right? This sac you're seeing basically, the greater sac and then this lesser sac where the stomach is known as the foramen of Winslow. And so basically foramen of Winslow is just a connection between the two great sacs, right? So if a patient has a bleeder within this place here, he has maybe an injury to a blood vessel around this place, the blood can track into this space and enter here. Moreover, what you also need to understand is that if a patient has peritonitis, inflammatory fluid can leave the peritoneal sac and go into the lesser sac, can leave the greater sac and go into the the lesser sac and cause an inflammatory reaction. And that's why when you do an exploratory laparotomy for a patient that has peritonitis, after you're done removing the purulent fluid from the greater sac, you must try and kind of like also check the lesser sac to be sure that peritoneal fluid is not there, inflamed peritoneal fluid is not there, because if you don't check and then you close up the patient might come back 2 weeks later with signs of peritonitis again, because the fluid from the lesser sac can just drain, and of course it has a lot of bacteria and inflammatory cells and can cause secondary peritonitis, right, in a patient. And so that's why it's important that when a patient has peritonitis, you check carefully to ensure that both the greater sac and the lesser sac do not have inflamed peritoneal fluid. This is very important for surgeons. It's just important for you to know this. Usually they might draw it in the exam and just point this arrow to you. That's what is this foramen called, basically? Or they might just put in an exam that the greater sac and the lesser sac are connected via a foramen. A foramen of this, B foramen of this. It's high yield, but it's not so high yield. Let me just use that word, right? I don't know if that answers your question, though. I don't know if that answers your question. Okay.
Sorry, doctor, can you repeat again how is called the I don't know, the structure that connects?
So there are two
both of them?
sacs. There are two
Okay.
sacs. The greater sac is formed majorly by the greater omentum. The greater omentum is like an apron that wraps the whole abdominal cavity. And the lesser omentum is like a kind of like a fold of peritoneum that connects the liver to the stomach and then the intestine. And then the fold over the stomach, that peritoneum that folds over the stomach forms a sac. It's like a ball. Let me just use that word. And that ball or that sac is known as the lesser sac. So there's a connection between the greater sac that's formed by the greater omentum and then the lesser sac that is formed by the lesser omentum that wraps over the stomach and the intestine. So if a patient has a bleeding in the abdomen, or has peritonitis, some fluid kind of like seeps through a connection between the greater sac and the lesser sac. That connection is known as the omental foramen, or the epiploic foramen of Winslow. Why it is clinically important is that when a patient has peritonitis, there is a tendency for the fluids to track from the greater sac, because the greater sac constitutes a large amount of the space in the abdomen. So once peritonitis happens, a vast majority of the fluid is actually stored in the peritoneal sac, the greater sac. So, however, there is a chance that some of that fluid that's inflamed and infected can go through that foramen and enter into the lesser sac. And so when a surgeon is doing an operation, when he's in the operating room trying to carry out an operation to manage a patient who has a ruptured, let's say ruptured viscous or something, he has to check the lesser sac, because when you open the patient up, you separate the rectus sheath, you separate the peritoneum, the fluid that will just pour out is found in the greater sac. But the thing is that the greater sac is also gravity dependent, and so you need to ensure that when you open the greater sac and you remove the fluid, that fluid is not remaining. Inflamed, effective peritoneal fluid is not remaining in the lesser sac. If the fluid is remaining in the lesser sac, if you close up that patient and you don't drain the fluid away from the lesser sac, you close up that patient, the patient can have a secondary peritonitis, because just the same way fluid enters through the greater sac into the lesser sac, fluid from the lesser sac can also go back into the greater sac, right? And that infective fluid that you didn't drain out of the lesser peritoneum can go into the greater sac and cause an inflammation, cause a secondary peritonitis post-op. So that's why it's also important. Likewise, if the patient is bleeding and it's in the peritoneal sac, you would have to check the lesser sac to also ensure that there's no bleeding in the lesser sac. And I said that the connection between the greater sac and the lesser sac is known as the foramen of Winslow or the omental foramen.
Okay, thank you, Doctor.
Yeah. Okay. So I'm going to talk about the epithelium, that's the layers of the guts. They use a fancy mnemonic known as MSMS, but what is very high yield for you to know is that the pathology associated with knowing this part here. And so these two aspects, the submucosal aspect and the muscularis externa, are very high yield concept because there are pathologies that are affected with it. First of all, the submucosal layer has a plexus of nerve that's known as the Messina plexus, and this plexus is responsible for making, the GI secrete a lot of fluid, right? The muscularis externa has another plexus known as the Ausbach plexus or mesenteric plexus that is responsible for motility. And how this is clinically relevant is that there is a condition known as acalexia, where the nerve plexus that is responsible for motility is damaged. And so this patient will present with, what do you call it now? Will present with a dilated esophagus, dilated distal esophagus. And then the patient will be presenting with dysphagia and inability to kind of like swallow both solid and liquid. So that's why that part is also very important. Secondly, you need to understand the difference between ulcers and erosions. Ulcers involve all the layers of the gut wall. So both the mucosa, the submucosa, the muscularis externa and the serosa can be affected in an ulcer. But an erosion just simply means that's just a sloughing of the mucosa layer, right? And that is very, very high yield for you to know. The interstitial cells of Kajal, the only time I've seen a question is an MBME. So the pacemaker, just like the heart has a pacemaker, which is the XA node, the GI tract has its own pacemaker. And those cells are known as the interstitial cells of Kajal. These cells generate an electrical impulse that helps with peristalsis. And so it seems that a lot of these cells or a lot of these plexus or interstitial cells are located more in the duodenum, and that is why you are able to have peristaltic actions, because of course the muscles of the GI are smooth muscles, and hence distension and all of that is supposed to generate an action potential, and the cells that are responsible for creating this action potential are the interstitial cells of Kajal. The next thing we need to know is how the histology of the GI tract. This is something that we have to talk about, and it's also very high yield, right? The histology of the GI tract. So every layer of the GI tract has certain cells that we're supposed to know. The esophagus is a place that is exposed to food bolluxes. So when you swallow food, both solid and liquid passes through the esophagus, and hence a tougher epithelium needs to line that esophagus. And the best epithelium for surfaces that have a lot of movement, a lot of friction, is a squamous epithelium. We cannot have a keratinized epithelium in the esophagus because even though the esophagus is exposed to a lot of friction, it's not exposed to a very high degree of friction, because food, of course, there's movement, there'll be friction, but it's not as high as when you're walking on the floor or when you're scrubbing something. That's a very high amount of pressure, right, for the skin, right? And that's why the epithelium of the esophagus is non-keratinized. The esophagus has two parts. It has three parts: the upper, middle, and the lower part. And so the upper part is more skeletal in nature. The muscles there are more skeletal in nature, and then the middle and the lower part are more smooth muscles, right? The stomach is a very, very important part of the GI tract. And of course, the stomach is responsible for many things. Digestion, which is the major thing. And yeah, so for digestion to occur, you need the food to be broken down to a very small surface, to a very, very small particle, such that you increase the surface area. And so there are two cells that are very, very useful in the stomach. We have the parietal cells and the Chef cells. The parietal cells, as you know, are the cells that help in acid production. And so the stomach has an average pH of 2. That is very, very acidic. And the acid that's found in the stomach is the hydrochloric acid. And when we're talking about hypertrophic pyloric stenosis, I told you how that is formed. The parietal cells are eosinophilic, and it's very important for you to kind of like recognize them. So let me show you this. And so I'm just going to show you how the parietal cells look like. And so these are the parietal cells that line this region here. These are the parietal cells here. This one's here. The ones you're seeing here are the parietal cells. These are the parietal cells. You know, these are them, parietal cells. And so these cells are eosinophilic. They are pink in nature, and they are responsible for forming the acidic part of the stomach. Now, the next structure after the stomach is the duodenum. So all that acid that is coming from the stomach has to hit a particular structure first. And the structure is hitting first is the duodenum. And so if you allow that large amount of acid to touch the duodenum, you literally just have the duodenum melting up. So the duodenum has special glands that are responsible for cushioning that acidic effect. And those glands are known as the Brunner glands. This is very, very high for you guys to know. The Brunner glands are more in the duodenum because the duodenum is exposed to a very large amount of acid, and so bicarbonate needs to be created to neutralize that acid. They're also known as Paneth cells. Paneth cells are cells, how I remember them, they're like the defensive cells of the duodenum. Of course, when you eat certain food, viruses and all of that, you know, you can't degrade them in the stomach. The acid might not be strong enough to degrade some organisms. And so the Paneth cells have a lot of, you know, secretory enzymes that are responsible for protecting the duodenum from microorganisms. And then we have some certain cells known as the crypt of Lieberkühn. So the basic function of the crypt of Lieberkühn is that it comes there, it stays in what do you call it? They have stem cells in this crypt of Lieberkühn. So the crypt of Lieberkühn are like depressions, like pits. These pits have stem cells. Of course, the GI every day goes through a lot of frictional process. So a lot of cells will be lost, and you have to replace those cells. And so the crypt of Lieberkühn comes and does that job, right? You also have, because the small intestine overall, both the ileum, the jejunum, and the duodenum are very absorptive in nature. You need to have finger-like projections that increase the surface area for absorption. And so you see a lot of villi in this region. Another thing I want to know, and which is very, very high yield, especially as regards the ileum, is that we have a group of lymphoid tissues known as the Peyer's patch. And the Peyer patch is contains some cells known as the M cells. And these M cells are the cells that serve as the conduits and the conduit for intracellular organisms such as Salmonella to infect. So the M cells are located in the Peyer's patch, and they are responsible for housing the Salmonella species that causes typhoid fever. Okay, so that's also very important to know. The other thing I would just want to say as regards both of them is that the largest number of goblet cells are in the small intestine, like they're in the ileum, goblet cells, the largest amount. I don't really know why physiologically this is supposed to be so, but well, that's how it is, and that's how we know it. So you might be asked in the exam question about where you have the largest amount of goblet cells. I think the first aid Q&A has this question. The first aid Q&A, the most recent one, has this question, so you can check it out over there. And At this point, do you have any question? I just want to talk about the high yield things you need to know here. The Brunel glands are high yield for you guys to know. And we have the largest amount in the duodenum because of the high acid production, right? Do you have any questions here? Okay. Now, there are some certain areas. The blood supply to the GI tract is, all of them come from the aorta. So it's the GI is a high pressure circulation, right? But the problem with the GI is that it has a lot of anastomosis and it has a lot of watershed areas. What do I mean by watershed areas? The distal end of a particular circulation terminates before the beginning of another one. Ideally, what you're supposed to have is that one blood vessel, forming the blood vessel forming at this level here gives us a lot of branches that supplies this region here, and then it terminates at this surface here, and then another one comes and terminates at this surface here. So this part of this side is supplied, but this part here are grossly undersupplied. And so this place here are prone to ischemia. This middle part here, so prone to ischemia. Now, the uniqueness about the GI tract is that if you have an embolus in this region here, blood supply won't be so markedly disturbed because the GI tract has a lot of anastomosis around this region, and so there are a lot of blood vessels that can anastomose and continue the blood supply here. But the one thing that affects the GI tract the most is hypotension. Why? Because hypotension is a global event. It's not localized. What do I mean by it's global? It means that when there's hypotension, there's reduced blood here. There'll be reduced blood here. There'll be reduced blood in all the collaterals. So you have gross under perfusion of almost all the regions, as against when you have a thrombus or an emboli. If you have an emboli here, anastomosis can cover up for the rest, right? Because of course you cannot have multiple embolas in everywhere. But hypotension is one thing that can cause ischemia in watershed areas, right? So they might give you a question about a patient that is having maybe mesenteric ischemia or whatever, or had severe hypotension, right? And the patient might start having abdominal pain and all of that. You need to understand that the reason why the patient is having abdominal pain is because there's so much ischemia going on, especially in the watershed areas, because hypotension drops the blood supply to all the anastomic regions. And so the patient will come down with that pain. The GI tract is supplied by 3 major arteries, and this is very high yield for you guys to know. Very high yield. You must know this at the back of your palms, right? The 3 major blood vessels that are supplied by the GI tract. So we have the celiac artery, which is the largest of them all, and it supplies the foreguts. Right? The celiac artery follows the embryological origin, and this is located at T12. So at T12 level of the vertebrae, or L1. And then we have the superior mesenteric artery that supplies most of the midgut, and this is located at L1. And then we have the inferior mesenteric artery that supplies the hindgut, and this is located at L3. You must know the spinal cord level that these arteries originate from. They are very, very high yield. You must know that for the exam. You must know that for the exam. The 2 regions that are prone to ischemia, the 2 of them, and this is another high yield thing I have to represent here. the two areas that are high yield for you to know for the exam as watershed areas are the splenic flexure and the rectosigmoid junction. Please, these two areas are high yield. You need to know them. You cannot go into the exam and see a GIT question that you will most likely not see. They will talk about the watershed areas. You need to know this. And then we have two syndromes that are associated with the Nutcracker syndrome and then superior mesenteric artery syndrome. So let me just explain them with a diagram so you can understand what happens here. In the Nutcracker syndrome, what you have basically in the Nutcracker syndrome is, let me explain this like this. It's an obstruction. So basically, the way the, this is the aorta, right? This is the aorta and this is the IVC. So the IVC gives off the left renal vein, which is longer, and then you have the shorter right renal vein. The superior mesenteric artery here comes over this blood vessel here. So it comes over the renal vein. And because the blood supply to this region here is very high flowing and the arteries are larger, they tend to compress the renal vein here. And so I told you that the gonads, the testicle, the right one drains into the IVC directly, but the left one drains into the left renal vein. And so if there's an occlusion here, it means that there will be a buildup of pressure that will come back to this point here. And so this patient can have varicocele. So the Nutcracker syndrome can present with left-sided varicocele. Also, once there is a buildup of pressure here, there can be stasis of blood, and you can have a thrombus that is formed. Okay, and the thrombus can flow posteriorly and go into the renal vein and cause renal vein thrombosis that will present with flank pain, and hematuria basically. So this is something that you have to know about the Nutcracker syndrome. The superior mesenteric artery kind of like compresses the renal vein because of how it comes out. And then the patient has a varicocele, left-sided varicocele, can have flank pain if the thrombus goes backward, and hematuria. The superior mesenteric artery syndrome is quite the opposite. And let me explain this. What you have here is that this is the aorta, and then you have the third part of the duodenum that passes here. It's vertical. So this is the second part. This is the third part. This is the second part, and this is the first part. So this is the second part of the duodenum. This horizontal part is the third part. And so the superior mesenteric artery crosses over the duodenum here. But God is so merciful that he put a pad of fat in between the superior mesenteric artery and the duodenum. And this pad of fat kind of like cushions the compressive effect of the superior mesenteric artery. However, when a patient loses weight suddenly, so the patient is on a weight-losing medication, this fat reduces in size, so there's a reduction in this fat. What does that subsequently cause for the patient? That subsequently causes the esophagus to be at the mercy of the superior mesenteric artery, and it compresses it. And this can lead to intestinal obstruction. So patients with superior mesenteric artery syndrome can have intestinal obstruction. The buzzword in a patient that has superior mesenteric artery syndrome is that loss of fat, weight loss, or on a weight loss medication. When you see that in the question, and this patient is having symptoms of intestinal obstruction, they might tell you the patient who had suddenly lost weight about 2 months ago, and all of a sudden starts having constipation, abdominal swelling, bilious vomiting, I want you to think of superior mesenteric artery syndrome. Okay. Okay. So is that clear?
Please, can you explain the parts that has to do with esophagus in superior mesenteric artery syndrome?
It's not esophagus,
Oh.
it's the duodenum.
No, you said esophagus. You mentioned esophagus.
No, so I'm sorry, it's duodenum. Sorry, it's duodenum. There's no esophagus there. It's the third part of the duodenum. Look at it. I said this is the first part of the duodenum. This is the first part. Here is the first part. Here is the second part of the duodenum, and here is the third part. The third part is the one that crosses horizontally between the aorta and the superior mesenteric artery. So I'm sorry, there's no esophagus. It's the duodenum that's affected. Sorry. This is what I was trying to tell you about the innervation and then the level of where the artery comes out from. You must know this for the exam. It's high yield. We're going to talk about the celiac trunk, and I'm just going to say a couple of things that are high yield here for you guys to know. So, does someone have a question? Does someone answer this? Okay. Now, the celiac trunk gives rise to 3 arteries, and among the 3 of them, these two are very high yield: the splenic artery and then the left gastric artery. When a patient has a bleeding gastric ulcer, the bleeding is most likely from the lesser curvature. And then the blood vessel that is commonly implicated in a bleeding gastric ulcer is the left gastric artery. The right gastric artery comes from the common hepatic artery, basically, but it supplies not as much as the left gastric. It doesn't supply a large amount of, it doesn't give a very large amount of blood, doesn't supply a very large amount of blood to the lesser curvature. This left gastric artery also gives a branch that's known as the esophageal branch. And this is very important because when a patient has vomiting, an alcoholic that is retching, that's vomiting, and the patient has Bohiva syndrome, this esophageal artery from the left gastric artery is the artery that is commonly implicated in Bohiva syndrome, and it is gotten from the left gastric artery. Now, there is a problem. If you look at this diagram, if your guess is as correct as mine, you will notice that this part of the stomach is not supplied by a blood vessel. I don't know how many of you guys noticed that. Yeah. And so the splenic artery supplies a large amount, but doesn't supply the fundus of the stomach. So if a patient has hypotension, it means the fundus of the stomach would be the first part of the stomach to experience a particularly significant ischemia because of the fact that the blood vessels do not go there significantly. Right. Another thing you have to know is that another high yield vessel that you need to know for the exam is this vessel known as the gastroduodenal artery that now gives rise to this right gastroepiploic. The right gastric epiploic supplies majority of the greater curvature of the stomach. Now, this gastroduodenal artery is a very high yield artery because if you have a perforated duodenal ulcer, the blood vessel that is commonly implicated in a perforated duodenal ulcer is the gastroduodenal artery. Does it make sense, guys?
Yes.
Okay. That is what I want you to take into the exam. So if a patient has an embolus here and there is no blood going to this region, it means that the fundus will be mostly affected. If the patient has hypotension, right, severe hypotension, the fundus is the first part that will be affected. Are you guys following me here? So those are the high yield things I want you to know from this picture for the step 1. Now, the venous system of the GI tract is unique because it has 2 drainage systems. It has the portal vein, and then it has the systemic drainage. So it has the portal drainage, systemic drainage. The systemic drainage goes into the IVC. The portal drainage goes into the liver. And so we have regions of anastomosis. We have about 3 regions that are very high yield. But what you need to know for the exam is how they present. A patient who has a problem with the liver, let's say the patient has a cirrhotic liver, it means that there will be a buildup of pressure here. And so the pressure will be greater than what you have in the intestine. And so blood doesn't drain into the liver, right? Doesn't go to the liver. Now, the left gastric vein, if that happens, if there's a buildup of pressure here, the blood goes backward. So there's a retrograde flow. And what does that do? Ideally, I told you that the portal vein takes like 80% of the blood to the liver. So that tells you how significant it is. If it takes about 80%, it means all its tributaries, that's all the veins that bring blood to the liver, are significantly take a large amount of blood. But the problem is that the systemic veins do not take so much blood to the IVC. So what does that mean? If the liver is cirrhotic, that high pressure will force blood to go in a retrograde manner to across the anastomosis and get to the esophageal vein. Now, the normal volume of blood the esophageal vein is supposed to take, let's say on a normal day, it's supposed to be like 10 mils. But because the liver is cirrhotic, there's so much pressure there, the blood from the liver flows, and then you now have 50 mils. What do you think will happen to this esophageal vein? What do you think will happen to the esophageal vein?
It will become engulfed.
It will become engorged. Yes, great.
But
Now, yes. You have a question? Does anyone have a question? Okay. It will become engorged. Now, when it becomes engorged, veins are capacitant vessels. They do not have the capacity to store a large amount of blood, an extremely large amount of blood. So they have their breaking points. And so if the liver is cirrhotic, blood flows retrograde manner, in a retrograde manner, goes to anastomosis, gets to the esophageal veins and excessively dilates them, and then they rupture. It means that blood will go into the esophagus, right? And then the patient starts, vomiting a large amount of blood. So patients with cirrhotic liver or liver disease that causes cirrhosis and a high venous pressure in the liver tends to present with esophageal varices. So that dilatation you mentioned is a varix. The vein is excessively dilated, and these veins are very prone to rupture. And when they rupture, they can rupture into the esophagus, and the patient can vomit them out. And you have that in all other parts of the GI tract. You have that in the umbilicus. You have that in this region here. Now, there is a procedure that you can use to circumvent this whole process. That procedure is known as TIPS, and we call it transhepatic portosystemic shunt, right? Transhepatic portosystemic shunt. Now, what you just do is that instead of allowing blood to flow in a retrograde manner to all the tributaries of the portal circulation, you just connect a shunt between the hepatic vein and then the portal vein. So blood just, directly just goes into there, because the pressure here will not allow blood to come in. And so when you create a shunt, you drop the resistance in the liver, right? And so blood will now move from the hepatic portal vein to the hepatic vein and then the IVC, and then it drains it. And then all these tortuous vein you are seeing will stop being dilated. But there's a problem, because when you are taking blood from the portal circulation to the liver is able to remove some metabolites like ammonia. It's able to degrade it. It's able to convert ammonia to urea that the body is able to excrete. But now that the liver is bad and you're not taking all the blood to the systemic circulation, you are transferring all the ammonia that is made in the gut and everything into the systemic circulation. And what happens? You will have an encephalopathy known as hepatic encephalopathy, because that ammonia will go to the brain, go to the heart, go to the brain, and then cross the blood-brain barrier, cause severe neurological dysfunction. I don't know. Does this make sense, guys? Is it clear, guys? Now, this is a very high-yield concept. I want you guys to pay attention. A lot of questions come here for the exam, and so I'll just basically explain what you need to know here. There's a line here known as the pectate line or the dentate line. This line represents the embryological fusion of the hindguts, right? Of the last part of the hindguts and the what do you call it now? And the ectoderm, right? The skin layer of the anus. And so how I remember this, basically, just remember the navel, right? The navel, N-A-V-E-L, navel. They like to test certain things, and the most high-yield things they like to test here is the lymphatic drainage, because of cancer formation in the lower part of the anus. Any cancer that arises above the dentate line tends to be an adenocarcinoma, because the epithelium there is more columnar. Any cancer that arises at this lower part below the dentate tends to be squamous cell carcinoma, and hence you must know that the cancer will go to the superficial inguinal lymph node if it's below the dentate line, and then the internal iliac if it's above the dentate line. Now, you need to know that the blood supply to this part of the part of the anus above the ectoderm is by the superior rectal vein, which is the last branch. It is the last branch of the inferior mesenteric artery. The superior rectal artery is the last branch of the inferior mesenteric vein. What does that tell you? That tells you that it is a very, very high pressure vessel to that area. Now, the nerve supply, because this part here is endodermal, the nerve supply will be a visceral innervation as against what you have.
Can you take that again? You're saying the superior rectal.
The superior rectal artery.
Artery is the last.
Yes, is the last branch of the inferior mesenteric artery.
Inferior mesenteric.
Yes.
Okay. All right.
Yeah. So the inferior mesenteric supplies the hindguts, right? Supplies the hindguts. The superior rectal artery is the last branch of that artery. So, does someone have a question? Let me see. Same questions here. Yes, so you're right, Dr. S. Dr. S, yes, it's a complication. Dr. Aksa, thank you for this mnemonics. Very lovely. Thank you for this mnemonics, right? Thank you for this mnemonics. You guys can copy this mnemonics. Very, very, very high yield. I'll put it on the group chats. I'll put it on the, someone can put it on the WhatsApp group so that people can have it. Thank you, Dr. Aksa, for that mnemonics. Okay, so now, what was I saying? Because this is endodermal in origin, the nerve supply will be a visceral nerve supply. But because this one is the skin, ectodermal in nature, it will have a more somatic nerve supply. So a patient who has internal hemorrhoids arise above the dentate line upward. These patients don't usually have pain. But if it occurs below the dentate line, the patient will have pain. And so they might ask you in the exam that this patient's symptom arise from which of the following region? A, above the dentate line, B, below the dentate line, and stuff like that. So you need to know if the patient has external hemorrhoids and it's painful, the origin is below the dentate line. If the patient has internal hemorrhoids and it is painless, it is above the dentate line, right? And the nerve supply, the blood supply to this region here is the inferior rectal, and that is gotten from the internal pudendal. So how I want you to remember this is that for the external, when it comes to the blood supply, everything here is I, starts with an I. Internal pudendal, inferior rectal, internal iliac. Basically, that's how it goes, right? That's how I want you to remember it. Everything about the blood supply below the dentate line starts with an I. Starts with an I. Everything starts with an I. Inferior rectal, internal pudendal, internal iliac. Everything, blood supply starts with an I. And anything that's is above the dentate line, superior to the dentate line, starts with an S. Everything there starts with an S. Superior rectal. Right? I don't know if that makes sense. That's the way I remember it, yeah. It's the way I remember it. So I'm not lost in the exams. The next thing we're going to talk about, I don't know, do we have any questions here? Okay. What drains the upper part is the internal iliac lymph node. And what drains the lower part below the dentate line is the superficial inguinal lymph node. Very high yield for the exam. Okay. Please give me a minute. We're supposed to have our slideshow in the next 10 minutes for reproduction. So let me see if I can finish this, and then we'll do our slideshow as quickly as possible. Right. Okay, so now the liver architecture, and this is where we're going to, but before I go to liver architecture, we're going to talk about anal fissure. And anal fissure is a very important concept because you need to know that there are painful anal lesions. External hemorrhoids and anal fissure are painful anal lesions. Internal hemorrhoid and the other one, what's the other one called? Anal abscess, anal fissure, external hemorrhoid, these are painful anal lesions or disease condition. And then internal hemorrhoids, maybe adenocarcinoma, are painless. The liver has a functional unit, right? That is made up of lobules, basically. So this is what I'm going to talk about. Now, you can see this big central vein here that drains into the hepatic vein. So the word central. So every area around this part is known as central lobular. Now you have here, that is the portal triad. So any region surrounding this side here is periportal. And so between the periportal layer and the central lobular layer, you have the intermediate layer. Now it's just common sense. You have the artery coming from the periportal area. It means that this area around the periportal area will have more blood supply. We have more oxygen, right? And this is in contrast to this area here that will receive less oxygen because all the cells here would have drained all the oxygen and the nutrients before it gets to this region here surrounding the central vein. And so if a toxin comes to the liver, The first cells that we exposed to it are the cells that are found in this periportal zone, and this periportal zone is known as zone 1. So viruses, the cells here will be exposed to viruses first. So viral hepatitis will affect the periportal region first before the centrilobular. This is commonly asked in the exam. It's very high yield for you to know. Also, if there is a general underperfusion of the body, these sites will enjoy blood supply and oxygen first compared to this region first, if hypotension is there. Now, this intermediate zone is the zone that is at risk of yellow fever. So they might just ask you in a question, but they don't commonly ask that. It's the centrilobular and the periportal they ask a lot. Now, this area here is the area that is at most risk for ischemia. It's also the least oxygenated area of the hepatic hepatic lobules, basically. Another thing you need to know is that this area, even though it's quite funny, because I would expect that the enzymes that are responsible for drug detoxification should be located around this area where there's blood supply. But on the contrary, that's not what happens. The enzymes, the cytochrome P450 enzymes are more located in this region here. So if blood supply doesn't get to this region, it means that this region cannot function properly, and hence the enzymes will not be able to function properly. So a lot of metabolites can accumulate in this region here and cause a lot of damage here. I don't know if it makes sense. Now, this is what you need to know for the exam, because they can draw this and ask you which of this region. I think in the first aid Q&A, they have a question about this, where they talk about which region will be most affected by ischemia. I think the first aid Q&A, I will drop that book in the group so that you guys can have it. They talked about this region. There's a question in GI that talks about this. Now, there are other cells that are important. We have the Kupffer cells. Those ones are responsible for phagocytosis. The antigen-presenting cells, they will help degrade the bacteria and present the antigens to the nearby lymph tissues, where the T lymphocytes processes them, analyzes them, and does the needful with them. The Ito cells are located in the space of this, has a peculiar function. Two basic functions, basically. When it's at rest, its job, produce vitamin A. When it is activated, it causes hepatic fibrosis. It can only be activated when there's injury, liver injury, so they replicate, secrete a lot of collagen matrix, and you have fibrosis. So the aim of the body is to try as much as possible to ensure that the stellate cells or the Ito cells are not activated. But the most high yield thing for you to know in this picture is this thing that I just explained here. Okay.
What are the functions of Ito cells again? Yes.
Yeah, so they have two functions. The first function is synthesis. They help to synthesize and produce vitamin A. That's when they are at rest. When you now trigger them, those cells now start misbehaving and they undergo fibrosis. They start replicating and causing fibrosis, basically. Right? So that's the two functions of them, to help in immune function, such as fibrosis, inflammation, and all of that, and then to produce vitamin A. Now, the biliary tract, the most high yield thing I want you guys to know from this is that once a disease condition affects the biliary tract, the patient can present with jaundice, and we can classify the jaundice into two. We can have painful jaundice and painless jaundice. If it's painful, you are thinking more of stones as the etiology. If it's painless, you are thinking more of a tumor. So you are thinking of more of an obstructive jaundice. That's what I want you guys to know. We'll deal about pathologies of the biliary tract when we get to pathology. And I know that you guys are aware of the femoral triangle. So the mnemonics for the femoral triangle, to know the borders of the femoral triangle, is known as SAILS. The S stands for sartorius. The A stands for adductor longus.
Longus.
Yeah. The IL stands for inguinal ligament. So anytime you think about the femoral triangle, just remember sales, inguinal ligament. And this inguinal ligament has a neurovascular bundle. The neurovascular bundle is known as there's an artery, a vein, and we arrange it as navel from, so navel. So this is from medial to lateral. So medial to lateral. The nerve there is the femoral nerve. And the femoral nerve, I would repeat, is not part of the femoral canal. So the AVEL is what forms what is contained in the femoral canal or femoral sheath. Femoral canal. The AVEL is found in the femoral canal. The femoral triangle has the navel, but the AVEL is the content of the femoral canal. Let me repeat that again. The femoral triangle, this triangle here has the femoral, the navel, the nerve, the artery, the vein, the lymphatics. But the femoral canal, as you can see, this is the canal, this dotted line around here is the femoral canal. And you can see that the femoral nerve is not part of it. I don't know. Does that make sense? This is what forms the spermatic cord layer. This is very high yield for you guys to know. ISTI. So it means that the external spermatic fascia is derived from the external oblique. The cremasteric fascia or muscle is gotten from the internal oblique. And then the internal spermatic fascia is gotten from the transversus fascia. You need to know this ISTI. It's your first aid. You can look at it. I'm not going to dwell so much on this, right? What I need to dwell on is this. You need to know the content of the inguinal canal, right? And so these are the contents. You need to know them for the exams. They are moderate yield. Let me not say they're high yield. They are moderately, yes, they're moderate yield. So you can know them. But this triangle, you must know. Right? The Hasselbalch triangle, where you have the inguinal ligaments, you have the inferior epigastric blood vessels. Can anybody tell me what this muscle is? The Hasselbalch triangle, the borders. Does anyone know? Okay, so that's an assignment for you guys. Okay.
Sir, could you kindly explain sail again? Sail and navel.
Okay, so sail is the borders of the femoral triangle. The S is the sartorius. The A is the adductor longus. The IL is the inguinal ligament. So those three structures forms the femoral triangle. Can you repeat the ligaments at the end? What ligaments exactly? I don't know. Do you mean the ligaments that form? Dr. Arish, you have to tell me your question properly so that I can know. Yeah, so the rectus abdominis forms the border. This muscle here is the rectus abdominis. So it forms the medial border of the Hasselbalch triangle.
Doc, we are not seeing
The inferior
image.
What image?
You stop sharing your screen.
Okay. Oh. I'm sorry. I didn't know that happened. I'm sorry. I'm sorry. I'm really sorry, but I didn't know that. So this is the aceribus triangle. This muscle here is the rectus abdominis. This is the inferior epigastric vessels, and this is the inguinal ligament. So this here is the borders of the Hasselbeck triangle. And why is this important? Because when you have an hernia originating medially to the inferior epigastric vessels, it's most likely a direct hernia. If it originates laterally to these blood vessels, it's most likely an indirect hernia. Let me go over that again. If you have a outpouching or herniation of the abdominal content through this triangle here, medial to the vessel, it's a direct inguinal hernia. If it comes out lateral to this vessel, it's an indirect inguinal hernia. And so we're going to talk about hernia, which is like the next topic. And so hernia basically just means a protrusion of the intestinal content through the opening or a site of weakness. I'm sure all of us know what an hernia is. And then we have different types of hernias. We have internal hernias and external hernias. The congenital diaphragmatic hernia is an internal hernia. The congenital diaphragmatic hernia is an internal hernia. And then we have the external hernias. The external hernias includes the femoral hernia, the inguinal hernia, the Spigelian hernia, basically. So basically, I'm going to talk about the Spigelian hernia and I'm going to explain something. Let me just use a picture to illustrate this so that you get it. Oh, they didn't give a picture, so let me just illustrate what happens. So this is what you have. This is the rectus sheath. There's a line here. This is the umbilicus. Goes down. And then you have the abdomen here. And then you have a fissure here. Right? You have a fissure there. So Spigelian hernia, these sites are called Spigelian, this region here, where the fascia, the transversus fascia is kind of weak. This area here, that's just almost lateral to the rectus abdominis muscle. This is the rectus abdominis muscle, RA. Right? And then this is transversus fascia. All these are like the external oblique muscles that are coming in and all of the internal oblique. So this transversalis fascia is weak. So this area here is the region that is most at risk of a Spigelian hernia. Spigelian hernia means that you can have it unilaterally. That's, you can have herniation through this side, and then you can have herniation through this side. Spigelian is like a trouser. So when you wear a trouser, this is a trouser. This is what it means. You know that the legs can come out of here, and then the legs can come out of here. That's the idea behind Spigelia, meaning that most often than not, it tends to be bilateral. So the guts can come out of here. The guts can come out of here. More like a trouser. When you wear a trouser, your two legs comes out, yes. So that's the idea behind Spigelian hernia. So one leg comes out, one leg comes out. It's the same thing. There's a weakness in this transversalis fascia on both sides of the rectus abdominis muscle, and the hernia comes out. And when you have that, it's called a Spigelian hernia.
And it's slightly below the umbilicus. From
Yes,
what
it's slightly below. Yes, it's slightly below the umbilicus. Yes, yes, it's this region here. Just some few centimeters above the pubic symphysis, some few centimeters below the umbilicus. That region there is known as the Spigelian region. Right? Okay. So let's move on. Now, the congenital diaphragmatic hernia is more, so let me just explain this. Let me use a diagram. I'll explain this so that we can move fast. We have a slideshow that we have to do today. So diaphragmatic hernia, right, has two parts. We have, let me just write it. I told you guys that diaphragmatic hernia is associated with what syndrome? What syndrome is it associated with?
So
Down
Down
syndrome.
Down.
Correct.
Down.
Correct. Now, this guy, a child, what causes the diaphragmatic hernia is that during embryology, the abdominal compartment is separated by a membrane that arises from the lateral wall and goes medially. This is the lateral wall, goes medially. So this membrane separates the thorax from the abdomen. This membrane is known as pleuroperitoneal membrane. Pleuro meaning the lungs, peritoneal meaning the peritoneal cavity. It comes together and fuses at the midline. But the first thing you need to know is that the pleuroperitoneal membrane forms a significant part of the diaphragm, especially the central part. The central part of the pleuroperitoneal membrane is formed contributes to the formation of the diaphragm. Now, the issue here is that the liver grows on the right side. So if there's going to be a defect, it's not going to be the central part of the membrane. It's not going to be the right side. It's only going to be the left side where there is no organ that is preventing or trying to prevent contact from going upward. This side is the freest part for a congenital diaphragmatic hernia to occur because there's no organ that is protecting the bowel from moving upward. So in infants, you have a problem with the pleuroperitoneal membrane. But for the adults, you have what we call a laxity. So there's a membrane that connects the diaphragm, the esophagus. Now, what level of the esophagus does the diaphragm enter? Does the esophagus perforate the diaphragm? Is it T8, T10, or T12? What level?
This level is the
It's
T8.
T8.
T8. Yeah.
Are you guys sure?
It's T10.
I'm thinking of T10, right?
I think it's T10.
It's T10.
I think it's T10. Now, there's a membrane here that connects this guy, or a ligament that connects the diaphragm to the lower part of the esophagus, and we call that ligament the phrenic esophageal ligament. Now, what happens here is that this ligament is tense and it holds the esophagus in place, such that there's no ability of any organ to protrude through this space here. So this phreno-esophageal ligament holds the esophagus firmly to the diaphragm, and so ideally it's not supposed to allow contents to go upward. But if there's a laxity of this ligament, it means that this esophagus can come up, and then there will be a space here where abdominal content can pass through. Let me say that again. If there is a laxity of that ligament, it means that the esophagus can easily just go upward. So let me show you what I'm talking about. This is it. This is what you now have. Because this ligament draws the diaphragm to the esophagus firmly so that there will be no space here. But if this ligament is now lax, the organs can easily just enter through here. The intestine can easily just enter through here and go upward. Now, when there's a laxity of that ligament, it causes diaphragmatic hernia in an adult. Of course, it will all occur in the left side, not the right. Now, we now have two types. We have two types of the adult form. We have the sliding herniatal and the paraesophageal hernia. What happens here basically in the sliding is that, you remember I told you that in the sliding, it's what happens in this adult type. There's a laxity in the ligament here. And so when there is a laxity in this ligament here, the esophagus can be pulled up and the cardiac the cardia, the gastric cardia can also be pulled up alongside it. And so this patient will be prone to gastroesophageal reflux disease. Another risk factor for this patient is obesity. So basically, even though that ligament is attached to this place, there's a amount of what do you call it now? What do I call it now? This part here, when you have obesity, fat now comes and stays between the diaphragm and the esophagus. And of course, what it does that it dilates this point here and the esophagus. And so if it dilates, if there's fat here, it means that there will be a space here. Now, if you now lose weight in that situation where there's a fat that's padded between the diaphragm and the gastric cardia, right, or the esophagus, if there's fat that now creeps in there, imagine what happens when you now lose weight. When you lose weight, that fat will be lost. And so that padding causes straining on the ligament that is here, the phreno-esophageal ligament. When there's fat here, let me try and explain what I'm trying to tell you guys. So when somebody is fat or has a lot of weight, some amount of fat is deposited here. And what does that do? That causes the phreno-esophageal ligament to be lax. That's one. Two, if it's lax, it means that the esophagus can go upward, and that's why it drags the gastric cardia alongside with it. Now, what happens is that when that patient loses weight, the fat here will reduce, so there'll be space here between. So this ligament is already lax. There's already space here, so it just pulls it upward, and that's what causes that hourglass movements that you're seeing here. For the paraesophageal, there's a defect just adjacent to the. So the ligament is tense. So let me explain the paraesophageal. So how you remember it is that for the sliding has an L. So laxity. So there's laxity and there's sliding. So remember sliding, you remember laxity. Both of them have LL. For the paraesophageal, from the word paraesophageal means by the side of the esophagus. What happens is that there's a defect. There's usually a small defect. So this is what you have here. This is what you have. This is the esophagus. Then you have the some part of the diaphragm here. And then there's a small defect here. And if there's increased intra-abdominal pressure, the intestine can just herniate here. Right? The difference is that the cardiac is here of the stomach. This is the cardiac of the stomach. It doesn't herniate through here. It's only intestine that herniates here. This is in contrast to the sliding that the cardiac herniates. And so these patients are not prone to having GERD. They do not have GERD. No GERD in the paraesophageal type. Does that make sense, guys? Does that make sense at all? Now, I mentioned about indirect and direct inguinal hernia, and I said that the indirect occurs lateral to the epigastric vessels, and the medial occurs medial. The direct occurs medial to the inferior epigastric vessel. What you need to know about this indirect is that it usually passes through the inguinal canal, and hence these patients tend to be much younger, right? Much younger, because when you are younger, this ligament is distensible. It's not as firm as when you are older. When you are older, this ligament is more stronger. It's properly reinforced as against when you are younger. When you are younger, these ligaments are not properly reinforced, and hence intra-abdominal content can go through there and enter into the scrotum. Now, this ligament is as a result of the patent process vaginalis. You know, the process vaginalis is supposed to close after birth, but it doesn't, and so it forms a conduit between the abdomen and the scrotum, and hence the intestine can herniate through. This is in contrast to the direct inguinal. Let me take you guys to this picture. Yes, this is the picture I was talking about. So in the direct, this fascia that forms the floor of the Hasselbeck triangle is known as the transversalis fascia. So when this transversalis fascia weakens, it causes a bulge beneath, that's between this muscle and this inguinal ligament. You see something bulging out here. That is direct hernia, direct inguinal hernia. So direct is as a result of the what do you call it? Weakness of the transverse abdominal muscle or fascia, basically, and it bulges through the Hasselbeck triangle. So you need to know this. It occurs medial to the inferior epigastric vessels or lateral to the rectus abdominis, where you don't need to know all that. The most important thing is to know where it occurs and what vessel. Does it occur medially or laterally? That's what is tested in the exam. And this tends to occur more in the elderly. Direct occurs more in the elderly, as against inguinal that occurs more in children. Femoral hernia basically is what happens when so basically when you see a hernia, the first thing you want to ask yourself is, let me give you guys an algorithm so that it makes it a lot more easier for you guys. So when you see a hernia, you want to ask yourself, is it above the inguinal ligament, above the inguinal ligament, or below? If it is below, you are thinking of a femoral hernia. Thinking of a femoral hernia. If it's above, you want to check whether is it medial to the inferior epigastric vessels, medial to the inferior epigastric vessels, or is it lateral? If it is lateral, you are thinking of indirect. If it is medial, you are thinking of direct. Medial, inferior epigastric vessels, you are thinking direct. Does this make sense, guys? And so the femoral hernia occurs below. The femoral canal is very strong. It's very, very strong. And so the femoral canal, once you have an intestine lodged inside the femoral canal, the opening of the femoral canal is very tight. And so patients with femoral hernia are more prone to strangulation. Strangulation simply means that the blood supply is cut off because of how, it's expanding, it's becoming bigger and bigger, and this femoral canal is very small and doesn't expand. And so it will cut off the blood supply to the distal. So the blood supply here will be reduced. The blood supply here will be reduced. And so this place here will become necrotic and the patient will present with pain. Okay? So that is that about that. That's all about hernia. So we'll continue here in our next class, guys. We'll continue here in our next class. I want to do the slideshow for reproduction so that we can just take a look at it. Just 5 slides or so. And then let me see whether it is ready so that I can send it to you guys. I want to send it to my phone and my laptop. Dr. Aisha, I'll explain the ligaments again. Before the slideshow. Now, I mentioned several ligaments that you need to know for the exam. These are the ligaments that you need to know for the exam, but I only focused on this one. And the reason why I focused on this one was because it's high yield because of this maneuver here. Now, all the ones that come from the hepatic, anytime you see hepato, anytime you see hepato, anytime you see hepatoduodenal ligament, just know that it is what do you call it? Anytime you see hepato, it means that it's gotten from the ventral mesentery. Okay. Anytime you see hepato, it's gotten from the ventral mesentery. Please give me a minute. Hepato. Anytime you see hepato, anything hepato is gotten from the ventral mesentery, and anytime you see gastro, it's gotten from the dorsal mesentery. Okay. Now, the important thing you guys have to know in the exam, for the exam basically, are the vessels that run inside them. But among all of them, the most high yield one is the hepatoduodenal ligament. That's what I was trying to say. The hepatoduodenal ligament contains the portal triad, and it's very important in this maneuver called the Pringles maneuver. I said that if a patient has a laceration to the liver, there are vessels in the liver that either come from the portal vein or they want to drain into the inferior vena cava. Now, what happens is that anytime the heart contracts and relaxes, that relaxing creates a negative pressure that sucks blood from all parts of the body to the heart. And so blood passes the portal triad, passes the inferior, passes the portal triad, goes to the hepatic vein, goes to the inferior vena cava, goes to the heart. And so if a patient is in the OR and the patient is breathing normally, you would expect that when you clamp the hepatoduodenal ligament, the bleeding will stop if it's a laceration, if the bleeder comes from the hepatic triad. If you clamp the hepatoduodenal ligament and you check the liver laceration, you can still see the blood oozing out profusely. It means that the bleeding is not from the portal triad, it's more from the hepatic vein. That was what I was trying to just say with the ligament. That's what all I've just been trying to say. That's all I said with ligaments. I don't know if it makes sense. Now, okay, so I'm coming. Let me share this slideshow for you guys. Just give me a minute. Okay, so we're going to start the slideshow in about 5 minutes. We're just going to take a look at it, and let me share my screen, and so we look at it. So this is slideshow on reproduction, and so we'll be going one at a time and trying to identify the images. You should know that these images are high
Doc,
yield.
you're not sharing your screen.
Oh, I'm sorry. Why am I always doing these things? Sorry. So this slideshow is kind of high yield because I usually get my images from the UWorld and the MBMEs, so they're very high yield. And secondly, some of the images from candidates who have written the exams in the past, I usually ask them about the images to see if they can recall any of the images that are there. And so I usually update the slides, and then I also I also update it by adding newer images to make it easy. So anytime I give you guys the slide, there are things that I've collected from a lot of students. I've asked them a lot. So if you're going to write the exam, it's going to be helpful to you. So let us start. All right. So what can you tell me? What can you see here, basically? What can you guys see here? What can you see here?
This is like
Bone. You can see bone.
teratoma.
It looks more teratoma.
It's like a teratoma.
Oh, this
Yeah.
is the ovaries. This looks like the ovaries, right? This is looking more like, well, let's say it's an ovary now, or like it's looking like an ovary, or it's outside the uterus, basically. That's what I want you guys to know here. This thing you are seeing here, this thing here, is a
The
fetus.
embryo,
It's an
and
embryo.
the ectopic
Embryo.
pregnancy.
Yeah.
Yes, this ectopic pregnancy.
Wow.
They can give you a question about this, and they would ask you, what is the commonest site that this pathology can occur? Right? A, fallopian tube; B, ampulla; C, isthmus; D, peritoneum; E, the bladder. They can just put that in the question for you. And so you must be able to recognize it first before you can answer the question.
Most
Or they
common
can
site
also
is
put it,
ampullary region of the
Ampulla.
fallopian tube.
yes, so the ampulla is the commonest site for implantation of the embryo. Another way they can put this question is, they can give you this and they ask you, what is this patient most likely had, which of the following risk factors? PID, infection, or PID, surgery, or something. It might just be some other things like that. And so you need to know the commonest,
PID will
yes,
be the factor.
exactly.
PID.
It's the commonest risk factor for ectopic pregnancy is PID. What can you guys see here?
Conjoined twins.
Congenital.
Conjoined twins
Conjoined
Joints.
on the abdomen.
Conjoint.
Yeah. So what?
Lobes.
How many days after fertilization does the embryo split for you to have conjoined twins?
6 weeks.
So the correct answer is greater than 12 days.
Yeah.
Greater than 12 days. So the embryo most likely splitted at day 13. What kind of twins pregnancy is this? Is it mo-di? Is it di-di? Is it mo-mo? Which one is it?
It's mono.
Yes.
I've got it
Momo.
mono correct.
Thanks.
Mono.
Mono.
Yes.
Mono.
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 Yes. Yes. Yeah, so it's mono. That's correct. That's correct. That's correct. Now, what can you see from this slide here? What are you seeing in this slide here? Can someone tell me what they are seeing in this slide?
Pelvic area. The sacrum.
It's the
And
unicornuate
then
uterus.
ovary.
One cornu of the uterus. It's the HST image, and you can see the contrast is going into the one arm of the uterus on
Yes.
the left side, and it means it's the diadelphys uterus, in which there are the two arms, and one arm is become visualized.
Yeah. So this is a unicornate uterus. It's a unicornate uterus. It's also looking like a bicornate in a way, if you look at it, but it's more unicornate than bicornate. So what happens here basically is that the paramesonephric dot is supposed to fuse in the midline, but it seems in this patient that did not happen, and so it's only one paramesonephric duct that developed. So this is a unicornate uterus. I want to show you guys what a bicornate uterus looks like on HCG. Just give me a minute. All right, let me show you guys what this looks like. So Just give me a minute. Can you guys see these images?
Yeah, yeah.
Can you see
Yes.
images?
Yeah, but it
Yes.
has gone
So
away.
you can see it's
It's back.
different. Yeah.
Like
Yeah.
a white.
So you can see it's different. Yeah, yeah. So you can see it's different from the one I showed you guys. You can see that it's different from this one that I showed you guys, right? You can see that it's different from this one I showed you guys. You can see it,
This
right?
is unique.
Yes,
It's
this
to
is
one
unique.
side.
Yeah, yeah. So go to the next one. Can you tell me what pathology you can see here?
Cleft lip and
Cleft
palate.
Cleft palate.
Cleft lip and cleft palate both.
Good. So this patient has cleft lip and cleft palate. Now, what teratogen do you think the mother would have been exposed to that would cause this patient to have cleft palate and lip?
Okay.
Medication?
Does anyone guess?
Medication.
Yeah, what medication?
Disturbance.
Mm.
What
What is that,
medication do you think this patient was exposed to?
For
There are several,
psychiatric
but you can
it's
list.
a psychiatric medication. Lithium.
No, lithium
No.
causes Epstein
No.
abnormality.
Yes, not
Alkaline.
So
Isotretinoin.
isotretinoin can cause it.
Yes.
Come again. What did you say, Doc?
Isotretinoic medication, the one we use to treat acne, can cause it.
Vitamin.
Yeah, vitamin A. Yeah.
Yeah.
Mm.
Can
Vitamin
anyone
A.
tell me yes? Can we list like 3 more?
Alkylating agents.
Sorry, what did you say, Doc?
Alkylating agents.
Okay, alkylating agents.
Anti-epileptic drugs.
Anti what?
Epileptic drugs.
Okay, yes, I agree with that. Which of them?
Valproate.
Valproate.
Vaporate.
Yes, vaporate.
So valproate, yes. Can we list like 2 more, guys?
Phenytoin.
Phenytoin.
Yeah.
Phenytoin.
What about warfarin? Does warfarin cause this?
I'm not sure.
Okay.
Not aware.
We have like 2 more drugs to go. Okay, so that's maybe an assignment. You guys can put it on the group.
Phenobarbital.
Yeah, it's still the same family with phenytoin. Can anybody tell me what this is?
The Paget's disease
Breast.
of Paget's disease of
Breast.
breast.
Paget.
Paget's
Paget
disease.
disease of the
Paget.
breast.
Now,
Paget disease of the breast.
what how do I put this now? Is Paget's disease of the breast from the ductal carcinoma in situ or the lobular? Which of them?
Doctor.
All right, great. So these are eczematous rash. It looks like an eczematous erythematous rash around the nipple. And then you can see what we're talking about here. So this is Paget's disease. They might ask you this in the exam. The cells that that are affected in the exam, they can ask you that. Now, can someone tell me what they're seeing here? What are you seeing here?
Placenta.
What are you seeing?
It looks like placenta.
Placenta.
Maybe I need to see as well.
Any hint?
Sorry,
Any hint?
what is this?
Like a sack.
Yes, you can see the
Yes.
hair part, so it will be dermoid.
Exactly. This is a dermoid cyst. This is a mature teratoma. You can see here, here. Yeah. So,
Is this a mature teratoma?
yes, this is a mature
It doesn't
teratoma.
really.
Where is the teeth?
It doesn't really look so.
Like
Yeah, yeah. You look the hair. When you see a structure that's derived from the ectoderm. In the ovaries, it tells you something. It tells you what kind of tumor is this? What class of ovarian tumor is this?
Germ cell
Germ
tumor.
cells. Yes, germ cells. Remember the mnemonics I gave you guys? I said TIDY, mature teratoma, immature teratoma, dysgeminoma, yolk sac tumor. TIDY. Right? What do you think this tumor is? This particular one?
Wow.
Oh wow.
Brenner, I don't know, because coffee bean.
It looks like it's
Yes,
nice.
it's Brenner's.
Yeah,
Brenner's tumor of the ovary.
No. It's not Brenner's, guys. It's not Brenner's tumor. Can somebody try again?
Fried egg appearance,
Okay. So what are you seeing here?
germinoma, and
Exactly. This is looking
seminoma.
like a dysgeminoma. This is looking like a dysgeminoma.
Mm.
This is looking like a dysgeminoma. You can see the whiteness, and then you have the. Have you guys fried egg before? Dr.
Egg
Miriam, I
fried?
know you fry a lot of eggs.
Of
Dr.
course.
Miriam, you
We
fry
have
eggs.
It's not a
fried
good
egg,
image of fried egg appearance.
fried
Dr.
egg, omelette, jam
Dr. Miriam, I know you fry a lot of eggs, so I don't like. Yeah. So yeah, so that's the dysgeminoma.
It doesn't really
Right.
look. This is not really. Doesn't really look like fried egg.
fried
Unlike,
egg, yes.
Yeah. So I couldn't get a really
Here
clear
we
picture
can
of it.
see the coffee bean
Please,
appearance
that
as
is,
well.
can we just see the image? I don't know.
Excuse
Okay,
me, Dr.
let me-
Oye.
Yes, Dr.
Can we
Miriam.
see the coffee bean appearance in the dysgeminoma as well?
Coffee
Yeah,
bean.
Why
we
is it
can.
written here? The grooves
No, it's
and
looking. What they said is that it mimics the coffee bean. It mimics it. So it's not really a coffee bean appearance. It just mimics it. It's not really a coffee bean appearance. Are you get what I'm trying to say? It
Looking
looks
like,
like it, but
Yes.
yes, it's looking like, but it's not it. That's what I'm trying to say.
But then how do we differentiate it on the exam? Because coffee bean is going to look like coffee bean, and this looks like coffee bean too.
Yeah, that might be. I want to get a clearer picture. I think this picture is quite controversial. I'm coming. Let me get a clearer picture for you guys. This is gonna take a bit of time. This geminoma. Okay. So let me get something that is a lot more clearer, right? Let me get something that's a lot more clearer. So I think this is much more clearer, right? I think this is much more clearer. I don't know. Can you guys see this?
Yes.
I think this is much
this
more
is
clearer.
Yes.
Yeah,
yes.
this is much clear. This is much clearer. So you can still see that coffee bean like stuff, that middle like groove like thing you're seeing here, right? But it's not coffee bean per se. I won't say it's coffee bean. What I think you should do is that if you are giving an histology slide and you have the suspicion that it's a dysgeminoma, I want you to kind of like measure the whiteness surrounding the what do you call it, the nucleus. And if it's quite significant, like this ones you're seeing here, I think you should go with a dysgeminoma. So let's try and look at this. Exactly, this is much more clearer. So the whiteness is much more distinct, right? If you can see this whiteness around the nucleus, it's much more distinct. I think you should go with a dysgeminoma. I hope I would have a Brunner's tumor. I don't think I have one here. Let me just Google a Brunner's tumor for you guys. So that I'm sorry. Brunner's tumor. Okay, so let's just see how it looks like. Okay. Okay. Do you think it's the same thing? Do you guys feel like it's the same thing? Because I feel
The
this is not
shape
the
is
same thing.
different.
This looks
Exactly.
like
No.
bean.
This one looks
this is
Exactly.
looks
oval
over,
shape.
over
Exactly.
and
Exactly.
lateral.
Exactly. So this
The
is a
white
way you can.
part
It's
is
still,
less.
yeah. So it occupies a large. You can see that the whiteness is not circular. It's not circumferential. It's more tilted towards one side. The whiteness is tilted towards one side. I don't know if you guys can see what I'm saying. Like the whiteness
Yeah.
is tilted to more. But when what we saw in the dysgeminoma is that it's more. Let me show you guys.
It's
What I'm trying
round.
to do. Yeah, it's more round. So you have the cell and then you have the nucleus inside, and it's like it's equal round. You understand what I'm trying to tell you? That the distance between here and here is equal all around. But for the Brenner's tumor, you have something like this, and the nucleus is more isolated to this side here,
One
and
side,
so you
yeah.
have more space here than against the other sides. Do you understand what I'm trying to say?
Yeah.
Okay. So let's continue, guys. I guess this is where we're gonna have to stop for today because it's 6 o'clock. We'll continue from here tomorrow. We'll talk about this tomorrow. We'll continue from here tomorrow. Yeah, it's 6 o'clock. So you guys have your UWorld session and we're past our time. So you guys should ready. Tomorrow we'll continue from here. I will do physiology of the GI tract. Okay.
Okay. Thank you.
Yeah. So
Thank you.
thank you guys for the
Thank you.
session.
Thank
Yeah.
you. Dalo.
Yeah. You're welcome. Yeah. No problem.
Make sure the recording class is given, please.
Yeah.
Okay.
Yeah.